ACGME board also ACGME board also changed its vision to explicitly add diversity and inclusion as a key element in its vision statement. And we've now developed new tools to assess programs and institutions for compliance with our new requirements. We've also developed learning communities, and we're going to launch those over the summer that are going to help to improve DEI practices through a chaotic process in which groups from the outside form learning communities, and then that will expand to more groups in the GME community. And this is called Equity Matters. So we've known that health disparities have existed for a long time. Back in 2002, the Institute of Medicine, now the National Academy of Medicine, produced almost a 600-page volume that detailed consistent across the board deficits in healthcare for minority communities that led to excess minority mortality. And this is Brian Stevenson, who is the author of Just Mercy and the founder of the Equal Justice Initiative. And he spoke at the AAMC's Learn, Serve, Lead annual meeting back in 2019. And his question was, why have we become comfortable with the disparities that exist in our society in healthcare? And he puts forward the hypothesis that we have an empathy gap and that we've become disconnected from those who are suffering because we're not proximate to them. We all live in our silos that are very much separated. And if you don't put yourself to the place of the hopeless individual, you won't be able to feel the willingness of the spirit to go there. And invoke Václav Havel in saying that you'll have to do this in order to really gain that empathy that we need in order to solve big societal problems like health disparities. I use the American Medical Association's health workforce mapping tool to actually map the cardiology practices in the city of Chicago with these blue dots. Over here on the south side of Chicago is the University of Chicago. On the downtown area, near north area, is the Streeterville community where the Northwestern faculty practice is. All along the North Shore and on the north sides of Chicago, where the population is predominantly non-white, there are plenty of cardiology practices. In the western suburbs over here, there are plenty of cardiology practices. On the west side, the near west side, where there's a very large African-American population, no cardiologists. And over here in a particular area on the south side, I'm going to show you Inglewood. Now, Inglewood was the subject of a New York Times article back in September of 2020, when it looked at the life expectancy in that community, it's largely African-American, 95%, and found it to be 60 years of age. If you take a 10-minute, 15-minute car ride from Inglewood to Streeterville, just north of there, where the Northwestern faculty practice is, you'll see that the life expectancy is 30 years greater, at 90 years. And in part, if you remember, there were no cardiologists in Inglewood, and there were plenty of cardiologists in Streeterville. And the geographic co-location of physicians and disease, we believe, may positively impact healthcare. And it's not just zip code that's important with respect to where physicians practice, it's where patients live, and patients actually seek their care. And this is an article that came out in US News and World Report last summer in conjunction with its hospital care rankings. And what it showed is that racial disparities exist in the Medicare program. So when you have Medicare patients that have the same insurance across the board, you would expect having the same percentage of individuals treated for the medical conditions that arise. So they looked at 3: cardiovascular medicine, cancer, and orthopedic surgery. And what they found from the time that they studied, 2012 to 2018, that Black patients received 67,000 fewer orthopedic procedures than if the care had been distributed equitably. And in part, it's because in African-American communities, there are very few orthopedic surgeons. And the idea of having the orthopedic surgeon in the community where the patients who have these disparities live in order to solve those disparities is part of the healthcare access problem that we're trying to address with our workforce solutions at ACGME. This paper from the Health Services Research really shows, again, that the more segregation that you have within residents and zip codes, that the less likely you are to find physicians, and that the odds of being in a primary care physician shortage area were 67% higher for majority African-American zip codes. And as the segregation increased in those zip codes, the odds of being in a primary care physician shortage area increased for majority African-American zip codes. So there's a problem with distribution with physicians where we're not getting physicians to settle in communities that have the greatest need for health disparity. So our mission is to improve health and population health. We've now added diversity and inclusion as a part of our vision statement. And our underlying theory here is let's educate physicians who are more likely to serve underserved patients and locate minority communities because we'd like to increase healthcare access. And we think by having this sort of relationship will improve trust, communication, and outcomes for those most at risk for health disparities. So if you want to find out who's going to practice in an underserved area, ask a first-year medical student. So the first-year medical students on the matriculating student survey from AAMC will tell you that African Americans will say, yes, I want to practice in an underserved community, in the gold bars here, about 63% of the time. Native Americans just under 60%, Latinx individuals just under 50%, and whites and Asians slightly less. If you ask a fourth-year medical student the same question, do you plan to practice primarily in an underserved area? Native Americans are just under 50%, along with Latinx individuals. African Americans are over 50%, still in the belief that they're going to practice in an underserved area. Whites in the low 20s, Asians in the low 20s as well. So when you look in practice, what happens, and this paper from the Cambridge Health Alliance did so, the odds ratio of you seeing a patient of your same race, if you're a Black doctor, if you're a Latinx doctor, an Asian doctor, compared to a white doctor, were 23-fold greater if you were a Black doctor and seeing a Black patient, or 19-fold greater if you're a Latinx individual seeing a Latinx patient relative to a white physician. And if you're an Asian physician, almost 26 times greater that you'll see an Asian patient as opposed to a white physician. If you look in primary care in particular, as did Peter Berg in this New England Journal of Medicine article, you'll find that Black physicians were almost 40 times more likely to see a Black patient in primary care than was a white physician to see a Black patient in primary care. This is referred to as racial concordance. And racial concordance isn't forcing people to work where they don't want to work. It's not limiting patient access to the best physicians. It's not forcing patients to see only doctors of their own race and ethnicity. Proximity is an important factor, but you also have physicians who have to be willing to work in disadvantaged communities and accept government reimbursement. And then also patient choice plays a role. And for many years, Lisa Cooper has been studying this along with Neil Poe and Janice Blanchard and other people. And what they realized is that in racially concordant relationships, trust, respect, communication, and self-advocacy are all elevated. The intention to adhere to medical advice is increased, and patient satisfaction is improved. There was a question about whether patient outcomes were also improved, but most recently there's been some interesting work that shows that that may be the case as well. My colleague Fatima Cody Stanford at Harvard says that when you think about the situation that we're in right now and vaccinating the population against COVID, that there are certain individuals who are prone not to want to receive the vaccine. And this is the minoritized population in part. And it's because of what we always thought of as the reasons that people have distrust in medicine. That is things that happened to enslaved women by Marion Sims, the father of gynecological surgery, Henrietta Lacks, and the misuse of her cells without attribution or compensation to her family and herself, and the Tuskegee syphilis experiment, where there was a known cure for syphilis, but that was not given to individuals because of the desire to see the natural history of the disease. And these were African American men. No, Dr. Stanford says that the reason that people are hesitant to take the COVID vaccine is because of everyday racism, and that framing the conversation about distrust in COVID vaccines in terms of everyday racism, that is the health, the lack of access and education, will distrust the minority communities. And so they will ask the question, why should medicine be any different than some of these other areas within society? And by addressing these particular issues instead of the historical atrocities, we might be able to get to the truth of the matter and to find ways in which we can vaccinate minoritized populations. I apologize, my internet signal just dropped, but I'm back again. And let's see if we can start up again.
Sure, thanks.
So we'll continue on. This other paper with Marcella Elsan and Fatima Cody Stanford as co-authors looked at delivering messages to individuals of different races. And they found that when the physician who delivered message about COVID information to Black patients, if that individual was Black, that it was a Black physician delivering information, that Black patients then showed a greater tendency to want to seek additional information around COVID. That this impact didn't actually extend to Latinx patients, wasn't found in this particular study, but for Black patients, it actually turned out that there was a pronounced difference. And the correlating editorial by Lisa Cooper on this one really puts it down in cold terms, that ensuring the messages are accurate, available, and comprehensible is insufficient. That recipients must also trust the messenger. That trust is most likely when information is delivered by a messenger who's known and has a positive relationship with the community, i.e. physicians who co-locate into areas with communities, people who are of racially concordant backgrounds. This paper by Marcella Elsan and my colleague Owen Garrick actually looked at another aspect of this in terms of health outcomes. It was published in the National Bureau of Economic Research and was very interesting sort of design. What they did was they took Black males in Oakland, California, and they then had those Black males go to either physician practices that had white physicians or had a Black physician. And these are practices that were established by the investigators. And that they found that when there was a correlation between patient and physician with respect to race, that is Black doctors seeing Black patients, that the Black patients were more likely to talk to the Black doctor about more of their health problems, and that Black doctors were more likely to write additional notes, longer notes about their patients. And that through some very elegant mathematics in the paper showed that cardiovascular disease impact could be reduced by 20% with respect to morbidity, 10% with respect to mortality, simply by having racially concordant relationships with the patient. And they found that this was probably due to the fact that diabetes and cholesterol screening were up, that invasive testing was up by 20% in racially concordant relationships, that the propensity return for repeat visits was up by 20%, and that even flu shots were up by 20% in racially concordant relationships. And you can see the importance of that now. The second paper that looks at this most recently was in the Proceedings of the National Academy of Science. And it really shows an interesting association. This is a correlation paper as opposed to a causation paper. And what they looked at, it was live births in Florida, and they found from 1992 to 2015. And they found that with the 1.8 million live births, that the newborn death rate for Black infants was about 3 times greater than that for whites. And that if you had racial concordance between patient and physicians, that is the Black newborns were treated by Black perinatologists, that you could reduce that death rate by 53 to 56%. It's an incredible number. And it doesn't tell you why in the paper because they didn't look for that. But what they did look at was this correlation, and that's what they found. They saw, interestingly enough, that no change in maternal mortality was experienced because of racial concordance. So it doesn't work entirely across the board. But I think we need more investigation to figure out what the phenomenon is that's going on when you have racially concordant care. The group at Harvard looked at this and they refer to this as race-conscious professionalism. And it's a way to describe the practice that Black professionals have in navigating the competing demands of professionalism, racial obligations, and personal integrity. The other two papers I show here, Wilkins and Brown, really talked about the tendency of Black and Hispanic physicians to leave one city in one type of community and then move to a different city with a very similar demographic in terms of the patients that they see. And the idea that we can change things in academic medicine through increased diversity is also present because minority scholars tend to study problems that impact disproportionately minority communities and often to their detriment in terms of funding, in terms of publication, in terms of H factor of their work. Things are different for minority investigators and the problems that they study typically. Racial concordance may also play a role in the recruitment of minorities into clinical trials. And you can see how important that is in this past year in which we're trying to enroll large numbers of minority patients into COVID trials, and to some degree with some degree of success. Minority faculty also serve as role models, mentors, and advocates for minority students in training. And we think that having minority faculty also helps to disrupt false stereotypes by humanizing the other person. It demystifies white intellectual superiority. It mitigates stereotype threat for minoritized learners in the environment. It disrupts the imposter syndrome for those individuals. It reinforces and restores confidence in our trainees when we have minority faculty as well. But we've not been successful in increasing the numbers of underrepresented minority individuals in graduate medical education. The green bars represent African Americans, the red, Latinx individuals. And over the last 15 years, we've seen that there's not been much motion in the percentage of those individuals in graduate medical education. And that's why just training a diverse population of residents is insufficient for being able to solve problems that we're trying to solve with healthcare disparities. Now, the disparity in physician number is too wide not to educate all physicians, and all physicians should be comfortable taking care of anyone. So we should all learn about elimination of health disparities. We should all learn about cultural humility. We should all learn about respect for life. And then patients are free to see whomever they choose. So you can't say that a racially concordant relationship is the only thing that's going to exist in society. So let's review the Acgme common program requirements and move forward. The first one is in Section 5. Section 5 is really focused on first-time pass rate, and the Acgme has probably been the culprit of the drive to increase the USMLE scores that residency program directors find desirable in their trainees. And that's because there's a great correlation between MCAT and USMLE Step 1 performance and USMLE Step 1 performance and ultimate first-time board pass rate, or first-time board pass rate. What each specialty review committee has been able to do for a long time is to set its own floor as to what constituted a successful first-time pass rate. Well, now the Acgme has changed its program requirements in Section 5 to make a level floor for all specialties. And now Acgme is also concerned with the longitudinal collection of information on board pass rate in individuals as opposed to just the first time pass rate, which was the single sine qua non of excellence. What we think is the important objective of the Acgme is to provide physicians who are going to be board certified. And then the ultimate pass rate probably has no difference. We don't know that it has any difference than just a first time pass rate with respect to excellence. And in fact, we have data that even suggests that maybe excellence isn't the thing that, that you achieve with a first time pass rate that's very high. What we see among URIM students is that they have lower median scores in standardized tests. And so that might actually lead to the exclusion of some of these students in residency programs that have a high premium that they place on USMLE Step 1, Step 2. Also, by eliminating USMLE Step 1, Step 2 overuse in residency selection, we can reduce its unintended consequence that it has on medical schools. That allows medical schools to now stress their distinctive strengths as opposed to having a national curriculum. And we think this will overall improve the ability to try to have a more diverse workforce within graduate medical education. I cite this paper by David Ash, published in 2009 in JAMA, that instead started to look at things that were different than what we usually looked at as excellence. Instead of looking at front-end excellence using USMLE Step 1, Step 2 scores, he looked at back-end excellence, which is the quality of care provided by the product of obstetrical residency programs. And he looked at the complication rate of folks who graduated from obstetrical residency programs and then correlated that to things that are qualities that he could actually maintain about the programs in which they train. And what he found is that those programs that selected residents with the highest USMLE Step 1, Step 2 scores didn't necessarily correlate to people who had the lowest complication rate, the highest quality practice. What he found, in fact, was that the residency program's complication rate itself was the greatest predictor of who was going to practice with a high complication rate and who was going to practice with a low complication rate, i.e. residency programs that had a low complication rate in practice actually led to physicians who had a low complication rate in practice. And the difference between low complication rate and high complication rate was 30%. And even more interestingly, it says that it actually they actually showed in their work that this persisted for the next 17 years of their practice. And that your training environment is really one of the most important things to determine your outcomes and what quality level of quality you're going to practice as a physician. It really speaks to the idea that we have to try to make residency programs as strong and functional as possible, because this is the way that many of our graduates are going to practice for the rest of their careers. So Common Program Requirement 1C is the second issue. And what we say in 1C is that the program, in partnership with the sponsor institution, must engage in practices that focus on a mission-driven, ongoing, systematic recruitment and retention of a diverse workforce of residents and fellows, faculty members, senior administrative GME staff, and other relevant members of the academic community. And so what does that mean? Well, who's the target of diversity? Well, I've been focused primarily on racial and ethnic diversity, but you can use this to actually look at a broad range of categories in diversity across the board. And this can include gender, orientation, religion, age, ability, national origin, among others. Now, remember, the mission of the Acgme is to improve healthcare and population health. So the focus of the workforce that you're going to target for diversity should be consistent with accomplishing this mission. We look at the AAMC's definition of underrepresented in medicine. And before 2003, there were only 4 groups of underrepresented minority individuals that the AMC recognized. There were Blacks, Mexican Americans, Native Americans, and mainland Puerto Ricans. Vanessa Northington Gamble, who was then vice president at AAMC and minority and community programs, went around the country to talk to medical schools and to academic medical centers about how they would like to define underrepresented. And not everybody had those 4 groups in their area, but they still wanted to be and needed to be involved in the effort. And so the concept of underrepresented in medicine came about in 2004, in which now we think of underrepresented in medicine as those racial and ethnic populations that are underrepresented in the medical profession relative to their numbers in the general population. And it gave a local perspective or a regional perspective to underrepresentation as opposed to a national perspective. So if you're at UCSF, Asians are quite overrepresented in medicine, but there are certain subcategories of Asians that are greatly underrepresented. And so Hmong populations, Bangladeshi populations are greatly underrepresented in medicine. And to be able to train those individuals who more likely will go back and serve those communities might be a way of trying to address healthcare disparities in those particular communities. So this way of shifting from the fixed aggregation of just 4 groups to look at the continuing evolving underlying demographics of our society and the profession was an important change. My colleague Cato Lorenzen in Connecticut would though say, let's not lose sight of the fact that we still have those 4 groups that still are greatly underrepresented. And even of those 4 groups, you can look at some groups that are really underrepresented with respect to gender and the intersectionality between gender and race. And so he pointed out at the National Academy of Science that African-American men are underrepresented in STEM and in medicine in particular, and that in medicine, if you look at this proportion, the purple bar representing African-American women, the green bar representing African-American men, it's almost 2 to 1 in terms of overrepresentation of women relative to men who are African-American. Now I use overrepresentation as kind of almost a fictional term because both are greatly underrepresented, but the idea that there are very few African-American men. In fact, last year there were only 585 in the entire country in first-year medical school classes shows you how dire the situation is. My colleague, Dr. Dale Okorodudu, has produced a film called Black Men in White Coats. It's quite inspirational in talking about how we need to figure out how to address the deficit or deficiency in Black men who pursue careers in medicine. I had a small uncompensated speaking part in that film. I think these are the sorts of things that we need to think about as we move forward with this. Well, here are the numbers. Last year's data from the Acgme showed that there are about 5.2% African Americans, just over 6,000, 6.2% Hispanic, Latinx individuals, just over 7,000, and now 356 Native Americans. That's up about 100 or so in the last 5 years. This is a dire situation because the numbers in our demographics show that the populations if you add them up, will turn out to be about 30% of the population now. And so when we think about what the race and ethnicity of individuals are in graduate medical education training programs currently, this is data from Sarah Brotherton and Sylvia Etzold, you'll see that only 65% of the African Americans who are in graduate medical education came from US allopathic schools, that we depend on international schools to provide us with almost 30% of the docs in training who are African American. The same thing is true for Latinx. Over 32% of the docs in Latinx and graduate medical education come from international training schools, while only 8.3% or only 60% come from allopathic schools, representing about 8.3% of the docs who train in the United States. In the allopathic community, the numbers are even worse than the allopathic community, and then the allopathic community and the osteopathic community. And that only 2.4% of the people who are in graduate medical education now who are African American came from osteopathic schools, With the proliferation of osteopathic schools, we have to do a much better job in those schools of increasing diversity in order to try to meet the goals that we have of increasing those individuals within our population for elimination of health disparities. Well, you can look at each specialty as a function of race and ethnicity to see where they're trained, because it's the specialties that really determine access to care for many situations. The number here in red, or the bar in red here, shows you the number of people who were in 2016-17 of this particular race and ethnicity. So everything over the bar shows you the things that people were overrepresented in with respect to specialty. Everything under the bar shows you those things that people were underrepresented in with respect to specialty. And what I show you here is that for whites, they're overrepresented in almost everything, internal medicine and pediatrics being the lowest things that are represented for whites, although because of the numbers, that pediatrics and internal medicine are actually some of the highest things that the highest fields that have whites. Asian and Pacific Islanders are overrepresented in these particular areas, underrepresented in those particular specialties. If you look at Latinx individuals, who represented 4.9% of the population in 2016-17, you'll see that these are the specialties, and you'll see, surprisingly, that nuclear medicine is one of the top specialties by percentage for Latinx individuals in the United States. And for African Americans, you'll see that preventive medicine is the #1 field by proportion for African Americans, as it turns out, and that there are a number of specialties that African Americans are underrepresented in. And then for Native Americans, the numbers are very small, so that you'll see that, for instance, in pediatrics, there are only 13 Native Americans in the entire country who are in training in graduate medical education. We have to do a much better job of increasing that. If you look at gender as a function of gender, specialties that are greatly underrepresented with respect to men are pediatrics and obstetrics and gynecology. Overrepresented, you'll see interventional radiology and orthopedic surgery. And if you look for women, it's exactly the opposite, where fields like pediatrics, that are 2/3 women, and fields like orthopedic surgery are only 14% female. So these are the sorts of areas that people are choosing. And I show you this slide by Brotherton and Etzel again to show you that in certain disciplines, specialties in particular, we are very, very low in underrepresented minority individuals. This is advanced heart failure and cardiac transplant. It's not a gigantic specialty, but you see that there are only two African-American individuals in the entire country. In a year like we had with COVID, you'll see that in ICU medicine, there are only 12 fellows in critical care medicine who are African-American in the country. The numbers aren't much different for Latinx individuals, 17. And you'll see that if you look at surgical critical care, if you look at pediatric critical care, if you look at anesthesiology critical care, those numbers are all in the teens. So what I implore is that any fellowship directors who may be in the audience, please think about looking at criteria that are different than those that you looked at before, that may be more inclusive in order to try to increase the deficit that we have in underrepresented minorities in the fellowship areas. Because fellowships are a great way to try to drive faculty in academic medicine, and that's a great need for many of our faculties. So what can programs do to increase diversity? Well, you have to think of diversity as a long-term strategy. We want to increase the number of learners coming into the pathway of medicine. And so you're going to have to look at pre-residency programs. Now, for about a decade or more, the LCME has put this onus on medical schools to look at pre-medical learners, do outreach to those programs, to develop pathway programs into medicine. Well, now the Acgme has developed parallel language for graduate medical education, so that graduate medical education programs are going to have to think about looking at pre-residency learners. So what can you do to reach out to medical students? What can you do to reach out to college students? What can you do to reach out to even pre-college students, high school, and grade school, intermediate school? One of the things that we think are important is to look at your resources and to figure out where barriers exist, and to work with programs within your institution or within your profession in order to try to drive more diverse individuals into the medical profession. We want to emphasize cooperation between programs as opposed to competition. What we don't want to do is have one residency program compete with another residency program up the street to try to buy or coerce residents in some sort of way into their particular program. And now that being said, if you have a visiting clerkship program for fourth year diverse students, if you have a second look weekend recruitment season for diverse students, continue to do that, because we think that's important in order to enhance the critical mass of individuals in order to drive diversity. But on the other side, don't use your resources to compete one against the other, so that those resources that could better be spent in creating new programs to introduce STEM with respect to medicine to younger students, or to find research opportunities for college students and medical students who are early in their careers, to think about driving those people into your discipline. And if you show active work and pathway programs, eventually showing tracking of participants, even if your actual resident numbers don't increase for the next several years, your program will still be considered to be in substantial compliance with program requirement 1C. We're changing the analogy from pipeline to pathway in recognition of the economic troubles that Native American populations have had with pipelines. And the pathway analogy works very well. People enter the pathway, they don't deviate from the pathway, and they come out on the other end of the pathway in the same sort of way. And these pathway programs we think are important in STEM, because many STEM programs in your community may not approach the medical institution in their community. We know that half the institutions that Acgme accredits in graduate medical education don't have a medical school. So even if your medical school had the requirement from the LCME to do this work, there are still half of graduate medical education programs that don't have a medical school that can do this. And so we want you to partner with your STEM programs, to use the resources that you have in terms of having mentors, opportunities, research experiences, and to reduce any barriers that you have that actually stop people who are younger from coming into your environment and then being able to benefit from these sorts of things. Systematic retention we talked about here, and that's the idea of trying to figure out what we can do to increase the ability to have people complete our program who start in our program. There are currently Acgme requirements to have an individualized learning plan for each of your residents. Regularize these learning plans so that it doesn't seem like you're a deficit learner if you happen to have an individualized learning plan. You should make sure that we try to remove the barriers that may impede successful advancement of trainees. And we have to make sure that we look at our numbers of people who are being dismissed from residency programs. And this is really data that comes down to thinking about the environment itself. Because what happens when you increase diversity in an environment that's unaccustomed to it? Well, you'll lose the residents who are in that environment. That is, if you don't mitigate cultural underexposure and indifference, that you don't cease to try to prevent stereotypical projections from taking place, that you don't reduce environmental triggers that trigger the imposter syndrome, and if you don't effectively address uncivil behavior, you're going to create an environment that doesn't drive belongingness, doesn't drive inclusion. And we find that sometimes diversity education itself, that implicit bias training, mandatory demonstration of competence, also often engender resistance and resentment in the environment, because there are people who deny that racism exists. There are people who deny that there are biases against certain groups, and that it's the learners who bring in these deficiencies, as opposed to the programs and the institutions that have created these sorts of barriers that prevent successful training. So we have to find the most effective training to help people understand diversity, how and who to train, and what conditions you want to try to achieve success. And then we have to figure out what the persistence is, how often this training needs to be done in order to help. This is my colleague, Dr. Kamara Jones, who is a griot who tells wonderful allegories on race and racism, and she defines racism in 3 different ways. Personally mediated racism is the racism that you usually think of. It's bad actors, people who are engaged in biased thinking and discriminatory behavior. That's not the racism I'm thinking about when I think about what's going on in medicine, medical education. Internalized racism is also important, because it's the societal racism that a minoritized individual actually brings upon themselves, actually thinks about, and it is actually to their detriment that they engage in this sort of work. That's one of the things that stereotype threat reduction that we talked about earlier may come into play. But institutional structural racism is also an important element. We asked Dr. Jones to speak at the Acgme annual educational conference a couple of weeks ago. And she was the closing plenary and was the highest rated speaker of the conference, as it turns out. I suggest that you look at her Gardener's Tale and her other allegories on YouTube. Well, the idea of structural racism, it may appear as a subtle, unconscious, unintended structure or normative value that's based primarily upon privileges afforded to the dominant culture. And that's referred to as white privilege. It's unasked for, it's often unearned, and it's woven into society's fabric. Dr. Jones would say, do fish feel wet? It's so ubiquitous that it's very hard to separate out. But it turns out that it demonstrates how past mistreatment drives current inequities in a number of systems. And when you really have to ask the question, as Dr. Jones, how could racism be operating here? It's focused more on outcomes than bad actors, and so it's referred to as racism without racists. It's measured by outcomes like disparities, and the remedy requires a change in social structures. I'm often reminded of my favorite line from the movie Usual Suspects. It says that the greatest trick the devil ever pulled was convincing the world he didn't exist. Very recently, JAMA Current actually published this tweet with respect to a podcast. No physician is racist, so how can it be structural racism in healthcare? An explanation of the idea by doctors for doctors in this user-friendly podcast by the great Mitch Katz and Ed Livingston, who were JAMA editor and a deputy editor at JAMA. They did a 16-minute podcast that you can't find now because it was taken down. And the tweet has actually been deleted, as you can see. But before it was deleted, Dr. Aletha Maybank, who is the Chief Health Equity Officer at the AMA, who's been working tirelessly over the last 2 years to try to build AMA's presence in the elimination of health disparities, really has looked at this podcast and said, first of all, that JAMA has complete editorial independence from the American Medical Association, so it doesn't represent the American Medical Association's position, and that the podcast and tweet were wrong, absolutely appalling at its core, the demonstration of structural institutional racism. She's furious. Later on that day, WebMD published this article about the backlash that took place on social media around this particular podcast and tweet. By 11 o'clock that day, Jim Madera had released a statement that really spoke to the AMA's now increasingly prominent role in the elimination of health disparities and building health equity, and the work that it did back in November at its special meeting, where it actually decried racism as a public health crisis. And in fact, the work that Jim Madera did just a week or two before this podcast on the removal of artifacts from Nathan Davis, who was one of the founders of the American Medical Association, from the 46th floor at the American Medical Association offices, and putting them in archive, removing the name of Nathan Davis from the major award that the AMA gives every year because of his role as a slave owner and the subjugation of African-American bodies. Finally, at the end of the day, the editor-in-chief, Howard Bachner, wrote this, saying that he apologized for the lapse in judgment of having such a podcast tweet. The denial of structural racism is not a good thing to do, and that structural racism obviously exists. Well, the idea that there's structural racism, that people deny it, is really part of the overall process of how structural racism works. And in fact, that if you deny that there's structural racism, you don't have a conversation around it, you don't discuss it, it continues to persist. And one of the things that actually is very cautionary is that many of the people who we're asking in medicine to drive the conversation are often young faculty members who are of minority backgrounds, minoritized backgrounds, and they're often becoming the targets of people who don't believe that racism is an element in healthcare, and they're being accused of driving a conversation that is false. So we have to be careful in our learning environments that we don't stir up more, we don't engender more issues that are negative, that are very helpful in this. Let's talk about the inclusive clinical learning environment. Well, Dallin Boatwright, my colleague at Yale, actually published this work. Compared to white students, Asians underrepresented in medicine, multiracial students reported higher rates of mistreatment and discrimination based on race and ethnicity. And that underrepresented in medicine female students, because of the intersectionality between gender and minoritization, also reported the highest prevalence of racial and ethnic discrimination. This work from Carl Billamorio in the first trial looked at surveyed surgical residents and found that 32% report discrimination based on gender, 17% report discrimination based on race, 30% reported physical or verbal abuse, 10% reported sexual harassment of surgical trainee women, 65% reported gender discrimination, and 20% reported sexual harassment. And this came at the hands of families and patients, at the hands of residents, co-residents, and attendings, and at the hands of administrators and nurses. The idea that this exists has been around for a long time. I wrote one of these articles on this subject back in 2001, when I had a fourth-year medical student come to my office and was pre-rounding on an infant patient, and the mother came into the room and said to the student doctor that she doesn't want anyone who's gotten into medical school because of affirmative action touching her baby. So the resident left, went and talked to the residents and said, so the medical student left, went and talked to her resident team, and on work rounds, the residents asked the student to stand in the hall while the rest of the team goes in and sees her patient. On the attending rounds, the attending simply said, well, we'll reassign you. You don't have to go into that patient's room and be subjected to that. And that was the wrong way of handling that situation. Our colleague Alicia Fernandez at the UCSF has actually come up with a nice schema and published in the New England Journal of Medicine of how you should deal with these sorts of patients. And I hope every institution develops a policy around dealing with patients who are discriminatory in their actions. So you determine whether the patient is unstable or stable. You then find out whether they have good decision-making capacity. And with that established, you find out the reason that they deny your treatment as a minoritized physician. And whether it's bigotry or whether there may be clinically or appropriate or ethically appropriate reasons, then you figure out what to do next, and then you can negotiate, offer a transfer, accommodate, or accept unacceptable behavior by limiting it in any way that you can. But you have to address it, and you have to use that as a learning experience to try to make that minoritized individual who's standing in the hall feel a part of the team and bring them into the idea that this whole environment is someplace that you actually belong. Well, when Carl Villamorio's group followed up on this initial first trial with respect to discrimination, they looked at who was being discriminated against most, and they broke it down as a function of race, and they found that discrimination rates were higher in Blacks, and that 71% of all Black surgical residents were victims of discrimination. And that for Blacks, they felt that discrimination came in the form of different standards of evaluation. 40% nearly felt that the white residents were evaluated differently for being involved in the same transgressions that they were, where they were evaluated more harshly. That 16% believe they were denied opportunities because of race, that slurs and hurtful comments were experienced by a quarter of all surgical residents. They're mistaken as non-physicians in 62% of cases by, even in their work as physicians, they were mistaken as someone else in about 56% of the cases. There's a daily barrage of microaggressions that minoritized residents feel. This is another work by Darwin Boatwright, that minority residents were tasked with being ambassadors, and they were subjected to microaggressions at a much higher rate. Microaggressions are phrases or statements are made. Is that your real hair? Can I touch it? Your name's too difficult for me. Do you have a nickname? Well, it happens across the entire world to a minoritized individual. It's in all aspects of your life. It's rarely said with misguided love. It's daily insults and indignities perpetrated against marginalized people, and it's more than just annoyances. It's a cumulative reminder that you don't belong. And each microaggression on its own doesn't seem like a big deal, but it is a cumulative process of death by 1,000 cuts. It comes from multiple people, and since each one seems very small, it's exhausting to confront each one. You appear hypersensitive when you do. And it's often done without the awareness of even causing harm by the individual, but it causes harm. It causes isolation, invalidation, unworthiness, respect. It leads to an inability to predict where it's going to happen. So hypervigilance is something that the minoritized individual is subjected to. It finds a way into every part of every day, and it's a constant reminder that you don't belong. It can steal your joy, ruin your day. It's hard to address in real life because it's hard to see, and it's small things that can be easily explained away. But those subjected to microaggressions are more likely to exhibit depression. Lottie Derby at Mayo studied this. She found that minority students actually showed that they have a increased rate of depression symptoms. Their Maslach inventory scores show burnout in a more consistent fashion when they've been victims of discriminations and victims of microaggression, and that med schools must do more to improve the learning environment for minoritized students, because people who are burned out have the ability to focus that wanes, have engagement with work suffers. They have feelings of apathy and hopelessness, increased irritability, emotional exhaustion, lack of productivity and poor performance. And even without the hat of structural racism and implicit bias on, if somebody evaluates a resident who exhibits this, you're going to find deficiencies in that resident. And so one of the things that we have to be very cautious about is they lead to outcomes like this. The rate of withdrawal from residency programs for African-American residents is almost twice their numbers in residency training programs. Latinx individuals just slightly ahead. But the rate of dismissals, you look at 2015-16, 21% of all residents dismissed that year were African-American. and then only 4.9% of residents in training were African American. If you look at by specialty, the percentage of people dismissed in anesthesia, my specialty, was about 23%. In orthopedic surgery, it goes up to 43%. In OB/GYN, if you're African American or Latinx, you represent 40% of the people who are dismissed. If you look at the odds ratios of people who are dismissed from their training programs, tenfold greater Black than white in 2015-16, 12-fold greater in internal medicine if you were Black compared to white. Surgery 6 times greater, pediatrics 7 times greater if you're Black than white. And the intersectionality between gender and race is important. The Philadelphia Inquirer picked up this message from the Bill Morio study. Most recently, last month in Academic Medicine, a moving paper written by a second-year medical student at the University of Vermont, who's both African-American and gay, talked about his dealings with the suicidal ideation. When you look at the victims of discrimination and racism potential, you'll see that 1,200 surgical residents out of the 7,400 reported racial discrimination. 859 a few times a year, 368 a few times per month or more frequently. And that when you're the victims of living in an environment that's like this, burnout is highly increased in surgical trainees. Almost 40% report burnout, women greater than men. And if you look at suicidal ideation, 333 of our surgical colleagues experienced suicidal ideation last year, or in the year this was done, 2019, and it's greater for women than men. In such environments, you really have to be very cautious about how you conduct your work. And so we ask programs in our Section 6B6 in partnership with their sponsoring institutions to provide a civil, professional, equitable, respectful, and civil environment that's free from discrimination, sexual and other forms of harassment, mistreatment, abuse, and coercion of students, residents, faculty, and staff. This is Christine Porvath at the AMA Change MedEd conference, who speaks on incivility and the cost of it. And she says that people miss information right in front of them. How hazardous is that if you're a resident physician? Those simply around it are more likely to have dysfunctional and aggressive thoughts, although they may be unaware of the connection. And people experiencing incivility may struggle to get off the sidelines and back in the game. This is an important paper that was done by the National Academy of Sciences on sexual harassment of women. And it really suggests that we should diffuse the hierarchical and dependent relationship between trainees and faculty in ways that allows a more diffuse learning environment for women trainees, so that the disruption, if one person is a perpetrator of sexual harassment, is not so profound and damaging for the career of a single individual. The last thing I'm going to talk about is the Macy Foundation's conclusions on reducing harmful bias and eliminating discrimination in the health professions learning environment. They put forward 4 strategies for doing this. They think we need to build an institutional culture of fairness, respect, and anti-racism by making diversity, equity, inclusion top priorities. We need to develop, assess, and improve systems to mitigate harmful biases and to eliminate racism and all other forms of discrimination.
You know where we look for documented
we have to integrate equity into health professions curricula, explicitly aiming to mitigate the harmful effects of bias, exclusion, discrimination, racism, and other forms of oppression, and increase the numbers of health profession students, trainees, and faculty and institutional leaders from historically marginalized populations. Well, that was a lot, and I'm sorry for the technical interruption that we had. But if you have time, I'll be happy to answer questions. If you don't, please feel free to write or call, and we can have further conversation around this. Dr. Panda?
Thank you, Dr. McDade. I think, the information you have shared is vast, but I think it speaks to the immense problem that exists. And I think the first step to making any change is awareness. So thank you for creating that awareness. I had 2 questions that were sent to me by the chair of emergency medicine, who couldn't ask those questions himself because of a conflict. It was what are some high value interventions that we could start with for an organization like ours? And the second one was, how does nursing diversity impact physician diversity?
Well, I think diversity in the environment is important. As you see in the Macy Foundation's work, it wasn't just focused on physicians, it was on the entire healthcare environment. So having nursing diversity is equally important. It helps well, Soman Saha studied this at Oregon. What he did was he looked at the relative diversity within a medical school class. And then he asked the question in the graduation questionnaire, whether or not the medical students felt they were able to care for a more diverse population. What he found is that the more diverse the medical school class was, the more apt people felt upon graduation they can care for people different than themselves. And that's because you learn from people who are around you. You see how they care for patients. You see how they treat other people. And you understand that that's the level of dignity and respect for life that you have to show as a physician in those environments. So having diversity in the healthcare environment in general helps to humanize the patients you take care of. And that's extraordinarily important. Now, the ideas that the graduate medical education has brought forward have been collected by the Acgme in our instruments. So we have an annual program update that we issued for the first time in 2019. We have another one that was issued in 2020. We are now collating that information and forming them into practices that people say that they've engaged in that have been helpful in addressing the retention and recruitment of both residents and of faculty. And there are a number of different sorts of types of institutions, as you point out, that you have to right size the intervention for your particular environment. And we think that we'll be able to actually catalog those and make them available to the GME community probably by the middle of the summer. We have 12,000 programs now, and that's a lot of things to go through. Our office was very small. There are only 2 or 3 of us for a very long time. We actually have brought in some technology, natural language processing, to help us to try to dissect some of those answers out. And we actually did something else. We started a new award, Diversity Inclusion Award, in 2019. The first recipients of that actually showed in their presentation that there were 125 pages of information about what they did in this regard. We pulled out maybe 25 different elements of what they did, and we are now making those available to the GME public so that you can see what you can do at your institution that might parallel the work that the excellent program. We have 43 entries. We're putting them all up on our website as something that the community has done. And the final thing we're doing is we're launching Equity Matters. So Equity Matters' major purpose is to be an innovative group that will come up with additional solutions for us, that will identify deficits and problems that we have in the GME community, and then we'll craft solutions and then implement them at their institutions and then report back. So that's the purpose of Equity Matters. And that's going to start up toward the end of the summer as well, where we're going to start figuring out things that exist in communities, in the GME community, and then figuring out solutions to those problems that we encounter, barriers that we find.
That'll be very useful information for programs. Thank you. I'd like to turn to the audience if there is any question that you would like to ask. We have our leadership for GME. We have our DIO, Dr. Four, and our leadership for the CLEAR, Assistant Dean, Dr. Court. Do you all have any questions?
Hi, I wanted to thank you for a fabulous presentation. And I did have a question about your studies of the Concordance, which were just staggering and a little discouraging for those of us who are not concordant. And my question is that I wonder if there are any studies that look at trust for discordant physicians, just getting at whether establishment of trust improves that, and then sort of along with that, if there are strategies for, as you said, we're not making great progress yet at improving the numbers yet to improve the concordance. And so our strategies for how to deal with that in the meantime, how do we improve our ability, not just to our awareness, but also improve our trust?
Well, I think the important work was done by Lisa Cooper and colleagues. Lisa was a MacArthur Award winner, as a matter of fact, probably over now 15 years ago at least, for looking at this type of work. In her statement she published to that editorial I showed you, it really talked about the idea that you have to establish trust, and people who do that have credibility within communities. So I remember how excited I was to hear about Dr. Panda's work that she does with residents in her program, where they go out in the communities and they actually try to identify things in the community and elements of the community and try to understand it in ways that many programs don't do. And I think that that familiarity that you gain by being seen by the public in their environment, by understanding what resources exist in the environment, is a wonderful way of trying to establish trust. I mean, trust means that you are trying to understand me. It's a curiosity about people who are different than you. And I think those are the sorts of elements that actually help to build trust. It's showing compassion for individuals and treating them as human beings. It's making them feel like they belong in the space that you are trying to establish for their care. I think those are the sorts of things that you can do as a person who is discordant and trying to increase the ability to reach patients. And I think that everyone should learn how to do this because there are too few people who are available of racially concordant relationships. I think on top of that, you have to figure out how to co-locate physicians into those communities, because people don't leave their own communities in order to seek care and would go without care as opposed to moving out of their environments. And so to figure out ways of getting Asian and white physicians to practice in underrepresented minority communities is a goal as well. Now that one's going to be tougher because the resources in those communities is harder. The differences in terms of worldview are vast. And so to find ways and getting people to go there. But the group that really has helped to break down those barriers to a large extent are the international medical graduates. International medical graduates as a whole, irrespective of race of the international medical graduate, disproportionately practice in underrepresented minority communities. Now, often there are issues around communication and culture that haven't been quite solved in those environments, but I think that it shows the compassion, the commitment to those environments that you have to have in order to build trust in discordant relationships.
Thank you.
Dr. McDade, that was absolutely a fantastic talk. In fact, I have so many notes, I'm going to actually have to go back and look at this again to pull out everything you said, because it's absolutely very, very helpful.
Thank you.
As the chair of the Disparities Work Group, what we started was to look at those medical conditions and really focused on hypertension in the Black population in Chattanooga that we already care for and that end up in the hospital, especially those that don't have a primary care physician. So we have several quality projects as part of our CLEAR work, which are focused on that population. However, what I'm hearing from Dr. Panda and what I think I heard from you was that it's probably more important to go back and focus on really addressing bias and structural racism than it is even to look at those conditions which we currently have identified.
Well, I think, Dr. Court, there's a both and here. I think that we have to measure the disparities, quantitate them, and then try to identify where they're occurring. And maybe there's a structural racism solution, removal of a structural racism solution that actually may impact that. We know the social determinants of health clearly are part of that, but maybe there's something that we're doing with respect to our clinic scheduling. Maybe there's something that we're doing with respect to who's in the environment and what we're actually able to do in terms of education of our patients that may actually come into play with this that you're not looking at, because if all you look at is the numbers, maybe you're not seeing the processes that lead to those outcomes. The thought of really sitting down and doing reverse engineering, referred to as reverse ideation, about what could possibly be causing the outcomes that you see. Well, you have to measure the outcomes first in order to start. So I think it's a both and for sure. I think that the idea of structural racism as being something you can't see and that is so normed in our system that it's very hard to extract is really the important part of this. And as Dr. Jones would say, you have to always keep asking, how could racism be operating here? that causes the outcome that you're seeing. So I think you have to do both. You have to measure the outcomes, and I'm so happy that you're doing this in a regularized fashion, a routinized fashion, and then you have to do some reverse engineering to find out why you have the outcomes you've obtained. And I think solving those problems are the ways that we're going to really eliminate health disparities. Thank you for that work.
Well, I think the other thing which you mentioned is the whole question of the healthcare system is not patient friendly from the standpoint of scheduling, et cetera. One of the local physicians, Kelly Arnold, has the Clinica Medicus, and she actually has Saturday hours and evening hours all the time in order to address the population she's taking care of. And I think we really need to think about is having a 9 to 5 clinic really the correct way to go when you're dealing with a working population.
I think that's a solid idea. I think minoritized individuals typically don't recognize when they're victims of scheduling issues. I will tell you, when I was a child, I had to see an ophthalmologist. And seeing an ophthalmologist in my community, I lived in a hyper-segregated community in Chicago, on the south side of Chicago, I thought it was routine. You just pack a lunch and you go to the ophthalmologist because you're going to be waiting for 4 hours before you could get in to be seen. And this is how I thought healthcare was supposed to be delivered, because this is what I saw. And if you don't know any differently, then you don't know that that was really not the way that you should have been treated as a patient. But that's the point. I mean, that there are systems that are built and they're designed to obtain the outcomes they are designed to achieve. And so having a night clinic for people who have to work and can't take a day off makes a whole lot of sense. And if we can do work like that to try to figure out how we can better increase access, then you're going to have more patients who will come to you. And it may actually sort of mitigate the effect of not having people in their area, because they may leave their area to come to you if you have a program that allows them to come after work. So that's a wonderful idea.
Again, thank you very much. Wonderful talk.
Thank you very much for attention.
Thank you, Alan. Dr. Garcia.
Yes, Dr. McDade, sorry, I'm at a computer without a video. You spoke about at the GME level, being able to recruit underrepresented minorities. Being from a small program here in Chattanooga, that seems to be a very difficult challenge that we have here, especially without a feeder school directly in the local area. How do we help mitigate some of those challenges when you have much larger institutions with fancier names like Johns Hopkins and UCLA that have such an incredible funding capability to be able to sponsor 20 underrepresented minorities to come and do an away rotation, for example. And also looking at the millennial mentality where residents are applying to programs, usually not because they're looking for the best training program, but what suits they're close to family. Is it a great environment? Does it have a great work schedule, etc.? So we're battling as program directors to try to improve diversity within our resident workforce, but we have so many challenges working against us in making that possible.
Wow, so you come up with some very important challenges, Dr. Garcia. One of the things that I would say you should do is to start looking in your community right now at young people who may be in high school, who may come back for summers for college, from college, who want to pursue medicine, and to figure out ways of getting them interested in thinking about careers in medicine. I think that's going to be the solution to rural physicians in general, that in order to make a rural physician, the best thing to do is to find a person who comes from a rural background and then educate them in medicine, and then hopefully marry them off to somebody who lives in a rural community. The thought is that that you're not going to get people who come from that environment to come to a difficult environment just because you can offer them more money, I suspect, or because you can offer them, better food or a homey environment somehow. I think people will find that in many different places. And so I think you have to find people who are passionate about that community, which is why I started with the data from the AAMC on the matriculating student questionnaire and the graduating student questionnaire, because you can find people who want to go back and serve in these areas disproportionately as a function of where they came from. And this professional obligation that people have to want to serve their communities when they're done is something that's true. Now, not every minoritized individual is the same. People who are first generation immigrants or are the children of immigrants may have an entirely different perspective about it than people who are the descendants of multiple generation families that have been in the United States and subjected to some of the difficulties that those communities have been subjected to. So I think you have to be careful about who you recruit. And then get from them their own understanding. And then I would ask my faculty, a minority faculty who are there, what brought them and why are they serving? And what would they suggest? Because I think a lot of the answers about how you get more people is that you ask those people who are like what you're trying to recruit, what their solutions would be in order to do it and how they ended up there as well. There's a lot of wisdom in the community. And I think we should try to extract that wisdom as best we can and form solutions. That's really the value of our Equity Matters program. If we were to come up with a bunch of dictates from the ACGME and say, these are the things that you need to do, GME, I think people would kind of chuckle at us and do what they go ahead and do. But I think every one of the solutions that we're going to put forward actually came from the GME community. It's something that somebody in GME is doing in order to try to advance this work, which I think is what makes it more valuable. The last thing I'll say is, do you advertise at the Student National Medical Association, the LMSA, the Latin Student Medical Association as well? I think one of the ways that you can actually get people to come to difficult places to recruit is that you have a complement of individuals who talk about the beauty and the wonder of serving the patients in the community that they're in with examples of what you're able to do. And you will move the hearts of people who want to come and serve. It's why I left the University of Chicago. I was at the University of Chicago my entire career, about 38 years, before I went to Ochsner. I went to Ochsner because I was invited to go to give the white coat ceremony for the University of Queensland at Ochsner's ceremony. And while I was there, I talked to folks who were actively involved in Katrina. Who were standing on the decks of the garage at Ochsner's parking lot because they were the only hospital left in New Orleans after the flood. And when you talk to people like that and you see the passion that they have for the community and the dedication they have in rebuilding the community, it makes you want to join that sort of effort in order to help to improve the cases there as well. So you bring the people who are the heroes of what they do in Chattanooga, and you have them talk to students, and you're going to win the hearts and minds of a number of people who'd be willing to come to your program.
Thank you, Dr. McDade. Thank you for an excellent presentation.
Thank you for the question, Dr. Garcia.
I think Ms. Appling, our Chief Diversity Officer for the health system, has a question.
And I apologize, I only have my picture up this morning, but good morning and what a great presentation.
Thank
I
you.
had a question about, and you hit on it a little on a slide that titled, what happens when you increase diversity in an environment unaccustomed to it? And Dr. Garcia asked, kind of kicked it off there. So you mentioned belonging. Belonging is very important, making a person feel like they belong in that organization. So now we're starting to recruit. We get the people in. We've constantly educated. We talked about education now and what education we should put in place. Diversity, cultural competence, cultural implicit bias. So what's the most effective training, and how do we serve those people when they get here?
Well, I think that's a very, very broad question in terms of you got to do a lot of stuff.
Yes.
I think that as I said in that slide, you will have to figure out the best ways of training, the objectives you want from that training, and you have to, first of all, I think you have to create a sense of safety in the environment to have the conversation. because in many of these conversations, you're going to tell people who had no intention of hurting somebody else that they're actually hurting somebody else by what they do. And really simple things, small things, these microaggressions that we talk about, people are very much unaware of. If somebody has an amazingly dazzling hairdo and they come to work with it, there are going to be people who want to touch it because it looks so, you just want to reach out and grab it. It's like pica almost. And unfortunately, that you're invading the space of another person. You're dehumanizing them by doing it, and you don't realize it because you think that you can touch my hair if you wanted to. It's no big deal. Well, it doesn't happen to you from every day, from every person that you see, where you feel very put upon. It's like being a pro athlete in a restaurant where everybody comes up and wants to take a picture with you.
Yeah.
And it becomes a bit of a burden after a while. Ijama Uluwu, who wrote the book, So You Want to Talk About Race, has a wonderful chapter on microaggressions. And just looking at that really kind of helps to set the stage for what people need to know. And so I think a lot of what happens that really makes the life of minoritized individuals more difficult comes from lack of awareness.
Yes.
So I would start there. I would
Okay.
start building some awareness before I started telling people that you're a bad person. This isn't about being a bad person. This is about understanding, and it's about systems. As we said in well-being, it isn't the individual who's the problem. It's often the system that the individual's in that causes the problems for the individual. And so I think the same thing is probably true for structural racism. It functions at a level that really doesn't say that you particularly have to be a racist, but sometimes people hear that. They hear the word racism and they immediately go to that personally mediated racism thought and that you called me a racist. And I will tell you that Tom Naska, who is one of the most ethically driven people I've ever met in my entire life, when the family medicine group came to us in early 2019, wanting to include anti-racism as a curricular element that the Acgme should require in its common program requirements, if not in its own family medicine program requirements, Tom was taken aback by the term anti-racism. And it took a little bit of education to help him understand. And when I think it was the death of George Floyd that actually really brought him around. And now he understood that he could see things that he didn't see before. And now he wrote that beautiful statement that you saw that I showed as my third slide or so of the presentation. And he has become a true ally. And so converting people from being either indifferent at best or being adversarial at worst to being an ally is something that I think that we need to do in all of our environments. And we take care of people of all races and ethnicities, understanding what they're going through, understanding what people who are like them, who are practitioners, are going through is extraordinarily important. Kimberly Manning, who I follow on social media, is a great griot as well, tells wonderful stories and lines of tweets, as it turns out. And she has an exercise that she does with residents around their names. So you have somebody who starts in a residency program on the first day, they have a quote unquote difficult name. And people want to shorten their name, give them a nickname, call them Dr. S or whatever. And what she does is she asks everybody to say their name, pronounce their name phonetically so that people can figure out what it is. Ask them what they'd rather be called if they want to be called something else. Ask them what they wouldn't rather be called, and define that so the whole group knows about this. And she does this on the first day of training. And to me, that really sets up a dynamic saying that everybody's name is valuable. There was a very interesting article in Teen Vogue, as a matter of fact, that was about this same subject, where, if you take the time to learn my name, that means that you're valuing me as a person. If you don't, that means you're not valuing me as a person. And that someone's name is one of the most fundamental things that they have and they do, that you can do is recognize it. So that's small things that you can do that aren't so threatening to folks in your environment. And when they start thinking about these things, it moves you to the next thing, and you can start edging into this and then finally embracing it wholeheartedly. It didn't take Tom long. He got it right away, and he's become one of the strongest advocates for diversity and equity and inclusion that we have at Acgme. And it's nice when the leader of the organization feels this way.
Absolutely. Thank you for all of that. I'm not going to stay on long, but I did encounter something like that. Even it happens outside of the medical center also. I was at an event over the weekend and someone wanted to touch someone's hair. And at the event, this was a lot of people there. And they even asked, how long did it take to get your hair that way? They had them in braids. So people, I don't think it's intentional. Like you said, it's unintentional. They're just not educated. They wanted to touch the hair and that was inappropriate in that setting. So, and that happens at work a lot. And so once we educate our staff and just continue to educate, those things are definitely going to help. And you have given us a lot of material to think about today. So thank you so much, Dr. McDade.
Thank you, Chaplain. It's great to meet you.
You too.
I know it is past the hour, and the people you're seeing here are people who are really passionate about moving this work forward in our organization. So thank you. Are there any other questions? I think, the information that you have shared is a lot for us to really think about as we implement in our organization. And I think few take homes that I'm taking away is that if we cannot address the issue of racism in our workplace, it's hard to imagine how we will address the racial inequities faced by our patients that we care for. The other thing that I think I'm taking away is, I used to think about asking before I reacted personally is how could a lack of knowledge or how could racism be working here when I felt that I didn't belong? But I think now starting to ask that question on a broader platform in every meeting or in every policy that we make is something that I'm taking away. And the last thing is I think maybe we can start with a policy on dealing with racist patients that you shared with Alicia. I think that was a great framework.
Yes.
I just wanted to see if anybody else had any other thoughts before we close.
Well, one thing I might add to that is on your selection committees, to have someone who is very intentional, and it doesn't have to be the minority person who's on the committee, to ask exactly that question. Where could there be a disparate impact in what we're doing? Are we asking for a criterion that is more difficult for somebody who comes from a marginalized background to be able to achieve or be able to demonstrate in the way that we're typically looking at this? And that's what you have to do. You have to really deconstruct how you engage in your processes to figure out where there could be a possibility of a bias that can't be met, almost by definition, from minoritized groups. And if you look at them and you take the time to go through those processes, practices, it's not, things are the way they are because they're designed that way. And if they're designed to exclude, then they will. And that's why I hit pretty hard on the normative value of standardized testing. Standardized testing is really good at predicting what it's designed to predict. So if you want to figure out who's going to be at the top of your class in terms of grades in first year medical school, the MCATs are really good measures of that. And in fact, the committee that designs the MCAT really try to very, very hard to correlate these sorts of things. And they're very successful at it. But are we measuring the wrong thing? We measure what we can measure. We don't necessarily measure what matters. And what matters is how well that person is going to be able to practice medicine in the end. And does being a good first-year medical student mean that you're going to be able to practice in an effective way in communities when you leave? And I think we all know the answer to that is some of our best students turn out to not be the best clinicians. We often become academics. So I think that's something that we have to look at.
Thank you. And I just wanted to share, recently we were having to prepare our documents for our annual evaluation, and I was putting my documents together when something struck me, and I said, what is the value that the university places on the contributions to diversity, mentoring, and outreach that we do as faculty? And so actually send that email to our new Associate Dean of Diversity and Equity, who's been appointed at UTHSC, And she was very much intrigued, and really it's a discussion that we're going to do at an organizational level now. How do we add value to that? We have value in our promotions on how many publications you've had. What is your service? Where does diversity, equity work?
Well, that's an hour-long lecture, Dr. Panda. I mean, the work that Martin Feeder did at the University of Chicago has been transformative. And I have to think that Martin was moved by the work that I was doing to a large extent as to how they got the idea that they should value this. I spent a long time at the level of associate professor, longer than most. I mean, if you look at the plot of how long people spend as associate professor at the University of Chicago, I was at the far end of length of that. And in part, it's because I spent a lot of time working with young people, trying to improve their presentations that they do, trying to help them with their lab assignments, trying to ensure that we ran these pathway programs effectively. And we did it at the high school level, we did it at the college level, we did it at the medical school level. And every summer, my whole summer would be spent in running these programs at multiple levels. And you get no credit for it. I would take call as an anesthesiologist in-house. I come to work on Friday, I'd leave on Monday. The whole weekend, we'd schedule in 20-minute or 30-minute intervals the presentations for these students who would give these end of the summer symposia, and we'd work around the clock going through their talks, and I have TAs come in at different times and work along with them, and the presentations were just crack by the time they were done. And what I really wanted to demonstrate is how excellence really looks and that you can achieve it. And if you take a student who comes from a mezzo school and show them what excellence is like, they won't go back to that school and think it's acceptable to do what they've been doing, what they've been told. They make the teachers better by going back to those environments. And so, all that work, all those hours, no promotion. And the thought about it is that by the time we got to the end, they developed this whole parallel system that you can use to get promoted by doing what you do. And I think that's right. That has to be recognized, because if you don't get compensated for it in terms of dollars, you don't get promoted for it. People don't give you extra time. I'd go put an epidural in during the middle of one of these presentations and then come back and continue on. So you devalue it. If you don't give people the resources they need to be successful, it's saying that you don't really think it's an important endeavor. And so you have to support with resources and time and reward people who engage in the behavior successfully that you want to try to achieve.
Thank you. Thank you. Ms. Appling is texting me a few years ago. We had created a diversity award for our institution, which due to multiple changes and events, we had halted for a little bit. So she's texting me, it's time to rebrush that and bring that forward. So you're right, Ms. Appling, we need to do that. With that, thank you all very much. And thank you, Dr. McDade. We really appreciate the wealth of knowledge you have shared.
Do you mind, Dr. Garcia, I think, was trying to say something just now?
Oh, sorry, I missed that. Carla?
Yes, I just wanted to say, I think your most important slide, at least to me, and hopefully to all my colleagues that were listening to, was the slide about how residents and students were mentored during their training years was what impacted the way they practice medicine the most in their later years. And that's one of the things that my goal is to really, and hopefully with the help of Dr. Panda and Dr. Jack, is help faculty see how important their role is in shaping the future of our residents and how they take care of the community that they're going to serve. And you can't do that with a bunch of lectures, because they're tired of hearing lectures, about diversity or implicit bias. They want to see it in action. And so the only way you can do that is by teaching the faculty, who then can actually show them when they're seeing patients and call them out sometimes on their lack of compassion on the spur of the moment, because those are the experiences that they will remember, and then say, you know what, Dr. Garcia is right. That was not compassionate. I didn't address that person in the way I should have addressed them. And I think those are the most valuable experiences they can learn from in the future. But it's hard. Faculty don't want to call out residents on the spot, or maybe because of their own implicit biases that they have. But we're hoping to change the culture.
There's a lot of fear in medical education because of the hierarchy, and that you don't feel empowered to say things. I think Atul Gawande's checklist manifesto was probably one of the first things that people used to empower everybody in the room. When the attending surgeon touches a light inadvertently and contaminates the field, and nobody says anything about it, because no one will talk to that attending surgeon during the middle of an operation about something that is so important that actually can change the life of that patient. The operation can be beautiful, but you now have caused an infection in that patient that shouldn't have otherwise occurred if you had just spoken up and said, I think that your glove touched the light. That's what drives patient care. And so to empower people to speak up, to be able to say things, and to start with introducing everybody in the room, before the surgery starts, because you want people to feel free to be able to speak in the operating room. I've worked at operating rooms where the tension was so high, a scalpel fell off the field and went into the shoe of a nurse who was one of the scrub nurses on the team. And there was like a little whimper that she made at the time that it happened. And then she then said to the surgeon, may I have permission to scrub out now? And that was nuts. Everyone in the room, when they saw that scalpel fall on this woman's foot, should have been crying out with compassion, about, are you okay? Do you need to step out? And the tension in the room was so thick that people didn't feel empowered. And so allowing a little bit of a breakdown of the hierarchy so that people feel empowered, I think drives better patient care. And that's exactly the same thing that you say when a patient is being mistreated, to speak up and to say that I think that we could have done this better, or I think this way that we're treating people is probably not the best way to go. One of the things that I recognized when I was at Ochsner is that although Ochsner is a wonderful place, there are some things that were a little biased in how they treated people. And so while you're thinking about trying to provide the best access to care for people who have the best insurance, and ensuring that nobody with commercial insurance waits more than 2 days before being assigned an appointment, to have even in your mind the consideration of creating a separate phone tree for people who have government insurance that doesn't have that same 2-day window is problematic. And you have to have somebody in the room to say that during the time that people are thinking, that throwing out ideas about things that are going to become practice for a healthcare system. And I think that's the thing that you have to feel empowered to do. And if you don't say it, then no one else will say it. They'll have groupthink about what seems to be the most expeditious thing, and it turns out to be the exact wrong thing to do for the community.
One of the most valuable experiences that we have given our interns is we have a community advocacy rotation. And part of that community advocacy rotation is they have an experience where they have to choose one of their patients. And then they are given a scenario where this is a family with 3 kids. There is no car. They have to go everywhere on a bus. And they have a doctor's appointment at 9:30 in the morning. And so the resident actually has to start from the patient's home and walk to the bus stop and get on the bus and make it to the appointment, then wait the time in the appointment, then get a prescription filled, get the bus wherever they need to go to get the prescription filled. Then they also have to do groceries on the way home and make it and pick up children at a certain time from the school bus and make it back home. And it is such an eye-opening experience for our residents to realize when our patients show up 15 minutes late because they couldn't catch the bus on time, or why it takes them 2 days to pick up their prescriptions at the pharmacy and not being picked up immediately like one of us do. And their reflection papers on this experience is just great to see them having an awareness, hopefully, that will help them serve the community of the people they serve. So it's
Well,
one of
I
just a few little things that we've done to help, bring on awareness.
Well, I hope your residents become hospital administrators one day, because I think clinic
You and
managers
me
should
both.
do the same thing. Yeah, wonderful observation. Sounds like a
Yes.
great program. I'm not
I
surprised.
love Erlanger to have a bus.
I'm not surprised. When I first heard Dr. Panda talk about some of the things that you guys do at Chattanooga, I was extraordinarily impressed. And my hope is that you will submit to the Diversity Inclusion Award, now named for Dr. Barbara Ross Lee, next year.
Well, I think we have to revive a lot of things in pure honesty. Bringing back the black bag is what you and I had spoken about, and then walking in our patients' shoes. I think it's been done in small silos in just a department or two, but I think how do we bring it into the institution? And I think having these sort of presentations like yours today, where we are really highlighting the need for it to happen, while there is so much organizational change. I think what we've seen is as an academic community in GME, we start things and then leadership changes, priorities change, and you put things on halt, and you have to revive them and be persistent and make sure that these things remain in the forefront. And I think that is where we have to spend a lot of our energy, I feel, here. So looking forward to working together to make those things more part of the fabric of all the programs, rather than just in pediatrics or just in medicine or things like that. So
I think you're right. That was the Macy Foundation's first conclusion, that we have to make these sorts of things top priorities in institutions, and to drive them in a regular fashion. The winner of the Herb Nickens Award at the AAMC meeting last year is a colleague, Cato Lorenzen, who I mentioned in the talk, as a matter of fact. In his presentation, he showed a plot of interest in racism, as it turns out, as a function of years. And he showed how it kind of went up during the Obama administration, then tailed off, and then it stayed low for a while in the Trump administration, and went up. And he actually traced it for a little while longer beforehand. And these things wax and wane. And so you have it's like the gun control arguments. Someone gets shot at a school, or multiple shooting takes place, and all of a sudden the interest in gun control legislation goes up, and then it ebbs back down again. Not much change is made until the next shooting, and it goes back up again. Oh, well, I think we react in terms of crisis mode to things in our society, when I think solutions like these, and racism and issues with health disparities, need a constant sort of level of action and attention until we're able to make progress. And they can't wax and wane, and we can't lose the momentum that we've gained in this last year because of inattentiveness. I think it has to continue to be driven and up the ante, and try to solve the problems that have been with us for such a long time.
absolutely.
Well, thank you. I know you're trying to get away, but I held you back.
I'm actually okay. I think Dr. Mendriata, the chair of emergency medicine, was finally able to join us. And I just want to say thank you for sending your questions today. We did ask them, and thank you for joining when you could. Did you have anything else that you would like to add?
No, I'm very grateful for the presentation. And I think as we, as academic leaders, seek to create change, I think we have to look for opportunities. And again, I missed a significant portion of the Q&A. Look for opportunities to reconcile these really fundamental ideologies on equality and access to healthcare. But we have to reconcile this with the healthcare economic landscape. And briefly, I just wanted to ask, and you may have touched on this already, when I met with our hospital CEO yesterday, and funding for diverse initiatives just doesn't hit the radar of a lot of hospital CEOs who operate on a 1% margin. how do we as physician leaders, and I hate to say it this way, but to make change a reality, how do we monetize these types of initiatives so I can go to Wall Street, which is essentially what we're run by, even though we're a pseudo public hospital? How do we make these changes at the Wall Street level so it can trickle down back to having appropriate health care at the neighborhood communities?
Yeah, so there's a lot that's been written on the business case for diversity, and even the business case for diversity in medicine. I think that's a fabulous, approach to doing it. However, I think it's even more basic, that if you don't deliver care to populations, that you lose the individuals in that population who would be able to contribute. You don't know where the next Steve Jobs is or where the next Bill Gates is coming from. And what if that person succumbed to illness prematurely because of lack of healthcare in that community? Lack of equity in healthcare steals from everyone. You lose the contribution of everyone when you don't allow access. And that's one of the things that Kamara Jones points out, that racism doesn't just impact the people who are victimized by the racism. It's because of the loss of that individual's contribution that all of society may suffer. And what happens to society when that person wasn't there? It's the butterfly effect, right? When that person's not there in order to drive the next innovation that would have been fabulous for Wall Street. I think that we have to look at this as a larger societal problem. If you look at what we can do at ACGME, is we create a big lever for change. We have a requirement that says you have to do this now. And if you don't do it, then we will cite you. And if we cite you, then there's a risk of you losing your accreditation. If you lose your accreditation, then that's more than a 1% margin to many institutions. When I was chief academic officer for the Ashland Health System, graduate medical education brought in 67 million. That was a considerable amount of the bottom line of what that institution cared about. So it's important. Every one of those dollars is important, and you don't want to risk it. I think the lever that accreditation can bring to try to change behavior of organizations is where you could use our help to do the things that you think you need to get done. What I'm saying, though, is that it's bigger than that. People should want to do this anyway, but if they don't want to do it and you want to point out where the dollars come from, then you could break down and use this sort of thing as the lever that helps you to drive it. Medical schools have often said that the time that you get the greatest number of invitations to the big D Dean's office is when your LCME accreditation survey is coming around. Then you get resources poured upon you that you hadn't had for the previous 8 years of your cycle. And so if you don't get it done now, then you won't get it done at all. And I think the ACGME can play a similar sort of role in graduate medical education to that extent. And we're not citing people yet, so you can't use this as a lever at this moment. But the fact is that it will happen. And when it does, then I think people will be moved to act.
Thank you. It's a very insightful response. Appreciate it.
You're welcome.
Thank you. Thank you all. Dr. Bennett.
Hi.
Hello.
I was just struck by that bit of dialogue, and the concept of what does this represent to the success of organizations long-term? What does it mean to the success of society long-term? And I'm struck so much both by how you view this from a leverage perspective, but also how maybe CEOs view their relationship with their funding streams and their own responsibilities as leaders, how much short-term thinking seems to play a role in actual actions, wherein all of these things seem to have a bearing on really a much more infinite mindset of what an organization is, what it represents, what it might represent, its role in a society. I don't know if you had the opportunity to read Simon Sinek's book, The Infinite Game. It's a kind of description of how that mindset alters your point of view in what you invest in and what kinds of bets you put down in terms of longer term aims and goals. This seems to be such an important and poignant model for a more infinite mindset. If you're embracing your own community, or if you're embracing your organization as a stakeholder in the long-term good, if you will, I think it's a powerful element of a long-term mindset.
Well, you know, and Selim writes in exponential organizations around a similar sort of guiding principle, and that many of these very large corporations have these very broad social sort of missions where they're looking beyond just what's the next thing to do to what their overall global impact is going to be. And, you know, to see yourself in that broader context and the role that you play in that broader context, I think is transformational for your organization. And if you view this as, I'm just trying to create this widget, that's all I'm trying to do, as opposed to understanding that if this widget's created, what it allows the world to do, then I think it makes a whole different level of importance in terms of your mindset as to why you need to be successful in doing what you're doing. Thank you for bringing that forward, Dr. Bennett.
I think talking about mindset, you know, it's, I think the number of times, I'm sure others may be able to relate to this, that I have heard, you know, we really appreciate the work you're doing around this, Mukta, whether that's well-being or diversity, but this does not bring in money, i.e. that it's not an RVU generator. And I've had to reframe to think about and turn to wonder and curiosity to get above that. But that feels like a microaggression at times.
Yeah.
You know, if you are valuing this, you put it in the strategic plan as a checklist or because it needs to be there, but you don't operationalize it or put resources behind it, then where does it really stand? So yeah, thank you, Sudev and Jeff, for that feedback, and Dr. McDade for responding. With that, I think thank you for this discussion. And I just wanted to offer if anybody else had anything else to say. Dr. Four, I think you're still on. Would you like to say anything? I think that's Dr. Four's number. Maybe not.
Maybe not.
Yeah. Well, thank you, Dr. McDade. I really appreciate that. And I think Kim will be reaching out to you for some communication.
Oh, terrific. I sent her a copy of my slides if anybody wants them, and you videotape this as well, so feel free to post it anywhere you like.
I appreciate it. Already tweeted about it, so we are taking permissions.
Super. Take care. Wonderful to meet you all.
Thank you.
Bye.
Thank you very much.
Thank you.
Yeah, bye.